everyone's coming in from the waiting room. Hope everyone's having a wonderful day. Their week is winding down and going well. We're excited to be here today. Okay, it looks like most folks who are in the waiting room have made their way to us, so I'm going to hop in and get started. Like I said, welcome. Thank you for being here. I'm Liz Flannery. I use she, her pronouns. I'm the Director of Education and Leadership here at the American Institute of Dental Public Health, and I'm thrilled to be with you all here today as we talk about rural oral health equity and disability communities. We can go ahead and head to the next slide. So today I'm going to give us some quick housekeeping pieces before I hand it off to Dr. Sean Boynes to give our didactic presentation on rural oral health equity and disability communities. We will then go into a community discussion as well as any Q&A we have for Dr. Boynes. And then close out. So I hope everyone is excited and ready for an interactive session with us here today. We'll go to the next slide. We just want to take a moment and say thank you to our partners and go to the next slide. So some housekeeping for today. We are recording today's session. We will have recording and materials available in our academy after today's session, and we will email out when that information is available. Please be careful with PHI, PII on this session. We invite you to introduce yourself, share your name, your email, your organization in the chat. Again, the aim of this is for it to be a very interactive, community-based session. So please get us kicked off by introducing yourself. If you have any questions or having any technical difficulties, you can post those in the chat as we move along and a staff member will help you. We have Sam with us here today. We have Grace with us here today, Annalise, so one of us will chime in and help. And if you have questions about the presentation as we go along, please feel free to post those in the chat as well. Again, we will have time for Q&A as well as a robust community discussion after the didactic presentation. Can head to the next slide. Just giving a quick overview of AIDPH, our mission is to empower, to empower our community to advance oral health through science, education, and advocacy. That is what we're doing here today. We're looking at some research on oral health disparities through one of our educational programs. We do this work because we have a vision of a justice-oriented oral health system. Can head to the next slide. So our communities of focus here at AIDPH include LGBTQIA+ people, veterans, people with disabilities, and people in rural communities. And obviously today's session is focusing on rural communities, but if we head to the next slide, we'll see that we recognize that there is a large amount of intersectionality amongst our four communities of focus. So while we're talking about rural communities, today's session particularly we're focusing on people with disabilities in rural communities. But when you look again at those four communities of focus, we see several different points of intersectionality among them, and we see that reflected in our research and our programming. Can head to the next slide. So this is a little bit, you heard me mention just a minute ago, our academy, which is housed in a digital learning space, all of our programming. We strive to offer a diverse range of programming, so there's something that fits everyone's needs and scheduling. We have repetitive sessions like a series like this where you can earn a certificate after all of the sessions. We have standalone webinars and workshops all the way up to more intensive fellowships and our annual convening as our colloquium. Can head to the next slide. So just sharing some norms of our session, we want to remain, again, I mentioned that it's an interactive session. We want to make sure that we're respectful and kind to everyone. We are careful about patient information. We use names, first names over titles here for equity. Please come on camera, be involved. Like I said, introduce yourself in the chat and be present with us here today over the course of the next hour as we're here together. And head to the next slide. Okay, this is just a quick information about our sessions this year. And if we go to the next slide, you'll see that we are at the last session of the year. All of these sessions are posted and you can again go through them and earn a certificate for participating in all of them by completing a competency quiz at the end of each session. We also have CEUs available for this session, and we'll post information on how to obtain those CEUs at the end of the session. We can head to the next slide. These are our learning objectives. This was shared in our registration information and is tied to our CEUs, and this is what we will achieve by Dr. Boynes' didactic presentation. And the next slide. Dr. Boynes is sharing a disclosure that he is an employee of Avisis LLC and is an unpaid board member of Oral Genome. You can head to the next slide. So I'm going to be passing it off now to Dr. Sean Boynes, and just want to share, Dr. Sean Boynes is a trained dental anesthesiologist dedicated to advancing safe, effective, and efficient dental care of the highest quality with a focus on underserved and vulnerable populations. He has been instrumental in shaping policies that promote equitable access to oral health services, and I think we're going to see that reflected in his presentation today. So without further ado, I will hand it over to you, Sean. Thank you so much.
Thank you, and thanks for having me, and thanks to everyone who's joined. Can't wait to dig into this topic. It is near and dear to my heart. I do have one conflict of interest that wasn't disclosed that I will share, that my oldest son is on the autism spectrum, and that really weighs heavily into my biases into this particular topic. Just because we are focused on the rural environment, besides my first couple of slides, and when I talk about the National Council on Disability, when you see data or information, it is coming from that rural environment. I opted to try to stay away from that typical rural versus urban because of the versus is in the middle. And I think it gets confounding. So really just telling the story from a rural environment. So when you see that information or data, it's really coming from those areas that we consider rural. Next slide. I always like to include this in any presentation I do discussing the disabilities populations, just because I'm usually asked to keep hammering on this from parents in my circle. And that's trying to destroy the euphemism special needs and moving away from that. There's lots of research at this point that's coming out, whether it's the American Psychological Association, the National Center for Disability, multiple parent groups, that this term special, why it was well-intentioned and initially a good way to sort of move away from terms like handicapped or mental retardation, has sort of melded and migrated into those same sort of terminologies and pieces. Next slide. So I encourage us, whether you think Mr. Rogers is a controversial figure or not, the book that he wrote in the 70s called Everyone is Special really talks about these type of euphemisms in this particular story. King Friday, who you see there in the middle of the book, feels like things are getting too complicated in the land of make-believe, that it's hard to understand what people need, and it would just be easier if everyone looked the same and acted the same. And so he made everyone in the land of make-believe wear a mask. Of course, in the metaphor of this, he was very pretentious and very egocentric, so he made them put on masks that looked like him. As you go through the book, the gracious lady Elaine finally talks to King as he's growing frustrated with the fact he can no longer tell who's who. He can't really help anybody. The complaints have gone up that by putting everybody in the same group and trying to make everyone the same, or defining an individual by a group instead of the individual, that it's worse than it's better. And so at the end, the lesson he learns is that we're all individuals and we're all special in our own ways. Similar to how in the introduction of this particular webinar, we only use first names instead of titles for equity. It's along those same lines. Next slide. So what happens when we do this, and this is kind of where the research comes in and why I like to start with this particular topic, is it can lead to something called diagnostic overshadowing. When we try to group individuals into this broad base of category, it unitizes. And in mathematics and business, it's a way to understand large groups. So there is a value for it, right? And a lot of public health, there's a value to understand where disparities may exist and with what groups. But I think a lot of times from an upstream standpoint, maybe not paying attention to as those factors and as that methodology and ideology floats downstream, the message often gets away from what the intention was. And then individuals just get grouped. People look at the science or whatever the disparities were and say, oh, you're this, so you must have this. And so what ends up happening are biased treatment plans. And research tells us that, especially with this particular population, it most likely leads to overtreatment, but can lead to undertreatment. Next slide. So for those reasons, go. One more back. There we go. There it is. The World Health Organization provides a diagnostic overshadowing does contribute to a lower life expectancy for people with intellectual disabilities, provides obstacles with getting health care, increases risk, and the research tells us with a litany of health problems, but more research on diabetes, hypertension, and obesity. And then because of that, and there does tend to be a lack of training and familiarity with the process. So these individuals are often viewed as asexual. So women experience disparities in breast cancer and cervical cancer screenings. Thus, there's more cancer incidents within the population. And then the sexual health of women with intellectual disabilities is regularly ignored. And so just sort of a warning as we think about sort of the research and the public health aspects of what we do and how we do need to categorize to understand the data and understand where to have resource allocation, making sure that we get much better with our messaging and how this information flows downstream becomes really important, because even the best policies or the best intended research, as you can see here, results downstream into real negative consequences. Next slide. So for the population, there is a challenge of oral health. So I'm going to step down off of my one soapbox and climb on to my next now, really focusing on the oral health challenges within the population. So parents really do recognize that there's tons of challenges with dentistry. In the last year and a half, I've been really privileged to be able to focus most of my time and efforts within the population and specific to oral health in multiple states and really focusing downstream. And so one of the things that tends to come up for me is that there seems to always be this push of, well, we need more education or we need better oral health literacy. I can 100% tell you that caregivers, parents know that they need to brush their child or their individual's teeth 2 times a day for 2 minutes every day. They know they need to eat healthier. They know they need to do all of these things. But I think there's a lack of recognition and messaging in the way we look at education programs and the way that we really move public health forward that is starting to isolate out and really push parents, caregivers, and individuals away more from the system or even folks that are trying to help, because it comes off as pretentious or condescending. Because the truth is 75%, it's can be even higher depending on what research, and I've provided those below here at the slide, with disabilities struggle to find a dentist. And it's extra alarming that those that are sitting on the spectrum tend to have, even as young adults, high periodontal disease because they tend to be on different diets because of their sensory disorders. And so not being able to get regular care and not having the tools or the vehicles to be able to do prevention at home becomes a problem. Next slide. Now, there's been efforts, although late to the game, and definitely without much enforcement to date, to try to offset some of this. Up until just a couple of years ago, dental schools really weren't required or held accountable to make sure students were being trained to treat disabled populations. Up until 2019, which is only a couple of years ago, dentists just became where they were no longer permitted to turn away patients due to disabilities. Unfortunately, I can tell you from my standpoint, of doing a lot of mystery shopper analyses and working within states and government, that dentists are still turning away patients with disabilities. And I'll share some data with you later that will demonstrate that the main reason they can't get access is because of discrimination. Next slide. And that discrimination was echoed by the National Council on Disability. This is a report that came out in 2022, so just 2 years ago. They did an evaluation looking at a health equity framework for people with disabilities. And there were kind of these three, what I felt, show-stopping statements of the current health system. One is attaining good health has been elusive and unwelcoming for about 26% of the US population, which is where it sits with those with disability. It's created a healthcare structure that results in disease management utilization instead of prevention. And this is the one that I find as a parent to be very, very true. And when I go in to the healthcare system with my son, I have to view it that there's a really good chance that this is going to harm him more than help him. And I think taking a step back and really thinking about that becomes important, because whether it's in my parent groups or different stakeholder groups that we now work with through our nonprofit, this comes up time and time again, and the trust has really been evaporated, and there really isn't any trust within anyone working within the system at this point. Next slide. So there was this idea and process that was put out in April 2023 from the National Council on Disability of how we can start to incentivize, really looking at, is there a way to increase coding for medical necessity? Is there a way to start looking at definitions and coverage? Is there a way to bring value-based care in, which will be very important for the overall success of changing the system overall? Next slide. And it looks a little bit something like this. The challenges, it's to address these challenges, to address why providers aren't really seeing these patients, from lack of training and understanding to low reimbursement, cumbersome prior approval processes and bureaucracy, ongoing staffing limitations, attrition, workforce shortages, to lack of equipment and time factors, lack of available sedation and sufficient staffing. Really big issues to try to overcome within the population in order to facilitate that within the system. Next slide. So here are the recommendations: more money, and that always seems to be at the top. At this point, I do think it's starting to become a red herring, and I have real concerns that we continue to look at money as a solution. And by all means, there is a need, regardless, to increase the amount of money being invested. It obviously is not kept up with inflation that has caused more attrition, more dentists to pull out of the programs that are going to matter most to the population. But I think once that happens, it gets to be the centralized focus, and it's how do we just get more money in the system. And I'll point out, in Western Pennsylvania, University of Pittsburgh Medical Center did throw more money at the problem. In fact, raising the maximal allowance for the population to $5,000 per year, where the standard is $2,000, and they continue to see attrition within the population of providers seeing them. So focusing too much on money, which I think has been the issue over the last decade, isn't going to result in a better facilitation of care. It's needed, it needs to be part of it, but I think looking at these other pieces are going to be important just as much as putting more money into the pot. Next slide. So one of the things that we've done with the nonprofit that I work with, and also continue to work with the AIDPH on this, and I'll share some of the science and data that we had, is mystery shopper projects, which is basically having a group of mystery shoppers that call power analyzed, if I can make my own word up, a group of dental practices in certain states, and finding out what insurances they take, how long their wait times are, how long it takes to get in for a treatment visit, anything that they provide, notes that are captured. And we do this with 4 scenarios: a Medicaid child, an individual that's developmentally delayed but has an ability to pay, adult commercial insurance, and then a self-pay family. Next slide. So I'd like to point out, if you haven't seen this, this is a publication that was done and funded by the state of Tennessee through their Department/Council on Disability and Aging, in which both Harmony Health Foundation and AIDPH really looked at both the behavioral risk factor surveillance system for the state and a mystery shopper analysis, which covered about 1,400 dental practices in Tennessee. Next slide. So just some of the highlights here from the BRFIS data, which really focuses on adults and those with a disability. We found 47% of Tennesseans with disabilities reported annual dental visits, so less than half. And 1 in 4 Tennesseans with ID do not have a dental visit in the past 5 years. And as we dug into the data, even if they did have a dental visit within the last 5 years, the chances of any prevention being done within those appointments was slim to rare. That most of the time it was multi-surface fillings, extractions with sedation. And so as a result, to this access to problem, Tennesseans with IDD are about 4 times more likely to lose all their natural teeth. If you break this down between environments, those on the rural side tend to have a 3 to 5-fold increase in all of these numbers. Next slide. When we looked at the mystery shopper analysis, Tennessee children with IDD experienced the longest delays. To get in for a treatment visit, it was 127 days. To give you a benchmark, most states require in their contracts. So if you're a state Medicaid agency, you hire an insurance company or a benefits administrator to come in the contract, it says this is supposed to be 30 days. In Pennsylvania, it's 15. We have done this analysis in 6 states. We have not encountered one state where anyone is meeting that benchmark measure of 30 days. Next slide. So here are the key takeaways. Significant difficulty finding providers willing to treat IDD patients. There's a reluctance to evaluate IDD patients' dental needs, even with prior successful appointments. There's a lack of training and confidence among providers to treat IDD patients. And one of the big things, and I'll stress this a little bit later, is the administrative burdens discourage anyone from really going into Medicaid, not just in Tennessee, but in multiple states. Next slide. Just to kind of put this out, here are the 4 most recent mystery shoppers. Florida's brand new. That's why Samantha and Liz will tell you I was a little late getting my slides into them. We just finished the Florida analysis on Tuesday, I think. And so that one's just brand new. But you can see that dotted line is the 30-day benchmark. One, if you don't think we have an oral health crisis in the United States, we do. Everything is pointing to that. We don't talk about it enough. Florida is the only state where I see universal acceptance in the state of declaring it a crisis. And they have, even the Florida Dental Association. But you can see here just how bad it is, even if you can pay and you're trying to make an appointment, even if you have commercial insurance. Obviously, that orange line is those with IDD. I will point out, we designed these mystery shoppers so we can compare scenario 2 and scenario 3. So the only difference between scenario 2 and scenario 3 is that scenario 2, the individual has a disability. It isn't money, it isn't insurance, it isn't location. It comes down to disability. And at least where I grew up, we call that discrimination. Next slide. And if you do get in, say you do get in to see somebody that does accept you, which is about half dental care sites that will see individuals, it sits between 45 and 55 that will. If you do, chances are half the time you're going to go in for an initial exam and a partial pro fee or cleaning, if you get that, and half the time you're going to be referred somewhere else. And then guess what? You can't use your Medicaid insurance, can't use your commercial insurance because the place you just came from billed you for it. So now you have to wait an additional 6 months to get in. The other thing is almost 10%, 6.8 here on an average, will require a behavior management fee regardless of what your coverage is, which averages between $150 to $200. If you're coming from a rural environment, the average time to go round trip for dental care access is almost 2 hours. We have reports of it taking up to 4 hours round trip. So then we figured out we better ask what people can actually do. One, almost none of these families or caregivers can afford to take a day off work. And number two, $9.45 in gas is what they can pay or are willing to pay. And I can tell you a 4-hour trip, $9.50 in gas isn't going to cover for that. Next slide. So we do have this promise of personalized care, which we need. We need to stay away from categorizing, looking at these populations. Overall, this is what leads us to using sedation 75% of the time, even though only 25% of this population needs it. And what we need to do is start solving for the fact that we don't have enough personalized or customized care. The other big warning I'll say is when we look at Medicaid and Medicare, there is a gravitation towards the provider networks, the networks that participate, being more corporate entities. And what we found through our mystery shopper analyses is they are less likely to see the IDD population. It's usually around a quarter of corporate entities will see IDD population compared to 50 to 60% of those in private practice. Even when we look at safety net programs, they are higher, but it's still around 60 to 70% are willing to see. And so as they gravitate more towards a corporate structure, which is really based in that conveyor belt, Kentucky Fried Chicken, McDonald's methodology and thought process, because it's volume. You want to do the same thing on every patient. It really ends up leading to more disparities overall in the population because they're less likely to see them because they look at the population as really messing up their day-to-day process and what they need to do on their conveyor belt. Next slide. I just add this in here. You can check it out on your own. This is a great, Nira Birch is an individual that happens to be on the spectrum. She wrote this great blog, 5 Things I Want My Dentist to Know. I won't go into too much, but one, remember they have sensory issues. Remember there's a lot of anxiety. Remember there's usually dyspraxia, which means there's issues with communication. There's issues remembering to brush their teeth. And if they're having a bad day, especially sensory-wise, there's no way that you're going to want to have a toothbrush in your mouth. It causes just an excruciating experience overall. And I, as a parent, even as a dentist, I'm not going to put my child in a headlock to sit there and brush his teeth. It just makes it more traumatic and even worse. Next slide. So we are starting to see some changes, which is good. And we're starting to see this in the payer facility. Recently, we're seeing more value-based care. We're seeing more improvements at focusing at home care and moving out of the 4 walls of the dental offices. Next slide. A lot of this is being driven by the fact that in places like Florida, you have 12 members of the Senate and 8 members of the Congress, including the current Speaker of the House, whose child is on the spectrum, coming in and wanting to make a change. So they put these bills forward that required changes in the process. Next slide. We have issues with care team satisfaction overall with seeing the patients. I'll point out Medicaid reimbursement policies at the top, but this goes back to what I said earlier about don't let money be the red herring. They put it up top, is this 37%, but then look, right at number 2, which technically is still number 1, is their own lack of exposure and understanding of the population. Then right behind it's insufficient training. So I would encourage any researchers and those that do publications, don't fall for the process of what's going on here. If you take a step back, technically 69% of this answer is, I don't really know how to treat this population. Not really the money. The money's a good way if your ego may be standing in the way and you don't want to admit that. It's a good way if there's a lot of interest within academia to kind of push this aside and say we are training. But overall, it's the fact that there are issues with the training process and even the vernacular that's being spoken around it. Next slide. So just a couple of things that did seem to help. So 2 analyses, that's all we have. If there's researchers from academia, I encourage you to try to put more out. We have one from the University of Michigan that did say that their undergraduate dental education did not prepare them well. they do say if they were better educated, they would want to treat the population. University of Pittsburgh analysis here shows that individuals that have more exposure to anesthesia and sedation education, or even within the clinics where it comes in, that they end up, those individuals that either go through that selective or had that exposure just on sedation and anesthesia were more likely to treat individuals with disabilities in their private practices. And as you peel back this publication, you find that a lot of it's understanding medically complex patients, having better pharmacology information, and also knowing how to treat emergencies better. Those three things within this program are low. And I'll point you back to my previous slide, which had Pennsylvania in there. Even though Pennsylvania has some work to do in comparison to the other states, where Pennsylvania has two individuals with disabilities, although Pennsylvania still uses special needs programs at the University of Pennsylvania and the University of Pittsburgh, you will see that the wait times and the number of individuals willing to see IDD in that state are the lowest amongst all the states. So showing that having those programs are actually very beneficial. Next slide. This is my biggest pet peeve. Is the other thing is the excuse is that individuals with disabilities take longer. They have more complications. They have less, I got to replace their fillings more. So what I did is I took all the information I could from published research and just did side-by-side comparisons. When you look at anesthesia and sedation, including local anesthesia, there's really no statistical difference between individuals with disability and overall population. In fact, individuals with disability have less moderate complications than the overall population. Same thing with local anesthesia, slightly higher, but once again, moderate complications much higher in the overall population. Survival of restorations. Individuals with disability actually have longer survival times of restorations than individuals in the overall population. Silver diamine fluoride, please somebody do a study on this. We don't have any way to compare. So just in comparison, as you can see the numbers on SDF alone. We do have it with art administration, which is a special type of structure where you're really doing a filling and focusing on remineralization. You can see no difference statistically between the populations. Next slide. The other thing is they cost more. They do initially. This is from my FQHC and our program. As you can see, the more you see them, the less they cost over time. Next slide. This is my last piece on the bureaucracy. If you do see individuals with disabilities and you're in the Medicaid system, this is what every dental care team has to do. I really, really encourage you to go and look at Stephanie Lau's dissertation on this. She's actually an employment educator at Virginia Commonwealth University. She got frustrated because the big issue was that just like everyone else, if your teeth are bad, it's hard to get a job, especially if you have IDD. And so she went into this dissertation ready to destroy dentists. And this is her telling me this. And as she peeled back, she found it was the system that was the biggest problem because they basically outsource all the bureaucracy to the dental provider team. Next slide. So what can we do? We need to bring prevention outside of clinical walls. There's now new technologies, assistive technologies. We're trying to get more independence, trying to get people to be able to work at home a little bit better, trying to have new technologies that are available in order to be able to do this. Next slide. So one of the things that we have done at Harmony Health is we are looking at salivary testing and connected toothbrushes, artificial intelligence, smartphone apps, all these new technologies that are starting to be incorporated into dentistry, but really just not there. And what we're doing is looking at what are the impact of being able to do this. And so far, we're finding that it has a pretty substantial impact, especially in assisted and community living environments, where individuals can track how they're brushing, or systems can hold direct service personnel more accountable. We're also finding that salivary testing, especially point-of-care salivary testing, becomes great surveillance systems to be able to understand where disease burdens are at and the type of diseases that are available. Now, there's more to come on this. We're in the process of evaluating the data now and trying to understand where the impacts are at. But so far, we're seeing really good movement forward. To the extent that the state of Tennessee has actually expanded this program from a 1-year to now a 4-year program overall. So more to come, but I want to point out these enablement technologies that are going to become very, very important for this population and really allowed for prevention to start going into at-home or in assisted living facilities. And next slide. That's it for me. I hope I was entertaining and controversial all at the same time, and glad to go to the next portion of this echo.
Wonderful. Thank you so much, Sean. And to our participants, I invite you to come on camera if you're not already on camera as we move into our Q&A and community discussion portion of today's session. We have a really robust group here today, which we're absolutely thrilled about. So we're gonna actually move into breakout rooms in a little bit to house our discussions so that we can ensure everyone's voices are heard. But before we do that piece, I want to pause and see if there's any questions for Sean.
And Liz, we do have one in the chat as well from
Oh,
Luba.
perfect. Do you want to read that out, Sam?
Sure.
I can just go ahead and ask it if that's
Oh,
okay.
sure.
Yeah.
Thanks so much for your presentation, Dr. Boynes. I was curious, it might be controversial. I don't know. It sounds like you're into that. The whole like personalized care. I'm glad you pushed back on that because, we want it to be equitable, easily accessible, on par with what everyone else is getting. And so I'm just curious about your perspective on, the conversations that have been going on for many decades about a specialty being developed to serve the adults with IDD population in particular. You can draw those boundaries in different places. And then maybe somewhat similarly, a designation of medically underserved population for this group. Just curious about your thoughts on either of those.
So I'll start with the easiest one first, which is medically underserved, or the Heads Up Act. Big proponent of that. A lot of the research I presented here has gone to Capitol Hill. Yes, this population should be considered medically underserved. I think it's really interesting that there is pushback not only from other individuals that have that designation because they don't want additional populations in because they're worried about funding, to the agencies that are federally involved with this, not wanting to see budget go to states. And I think anytime that that's the case, then that assures me that it's the right solution and the right answer. When greed and power come into it and that becomes more pronounced, and that's more important, that people are willing to not look at the facts. And even if you followed the process of the Heads Up Act, you would note that HRSA, CMS, even the CDC was involved with moving the goalposts, even though there was the population had met it, and then they said, wait a second, we're moving the goalposts on you. I think anytime that you see that, that tells me that, yes, this should be a medically underserved population, and they know it. So that's why they have to do these other things. As far as where personalized care is going, it kind of falls in the same parameters of medical dental integration. If you look at the original grassroots, this was a punk rock answer, right? Things in the system are getting too bloated, right? If I say punk rock, if you were in the 70s, you had Rush and Emerson, Lake and Palmer, and they were doing 17-minute guitar solos. And then the Ramones and the Sex Pistols came along and they did 3 chords and made you feel good. And everybody remembered what rock and roll was about. We saw the same thing in the late 80s with hair metal bands and pop music getting, self-aggrandizing and kind of overdoing it. And then here comes Nirvana and Pearl Jam, once again, going 4 chords and giving you rock and roll music. And so I think that was what the initial push was. And then you saw the corporate pieces, the upstream pieces, grab a hold of that and figure out, wait, we're going to push back against this movement. We're going to stall it until we can figure out the capitalistic aspect of it. And those are the things that I'm seeing that tend to be very concerning. And so I think the most punk rock thing that we can do now in order to push back on it is say, okay, fine, dental system, this is how you want to be. I'm going to start doing things my own way and do it myself, DIY. And can these technologies and these new pieces allow for that to happen?
Wonderful. Thank you. And a super fun, interesting analogy there. Okay, so I am going to go ahead and open up our breakout room. Sam, if you can post our discussion questions in the chat, that would be fantastic. And we'll come back in about 10 minutes. I'll call folks back and we will reconvene and close out. And some folks will be staying here in the main room. We will serve as our own little breakout room here. And have a discussion here as well. Okay. I think folks are still going, but we can jump in and get started. Again, as we're having a community discussion, if you are so able, I invite you to come on camera so we can all see each other, and we'll look at the discussion questions here. So I'm curious, I think that this ties in well, if folks have thoughts around how dental professionals can be better trained to provide oral health care to people with disabilities, particularly in rural settings, and how that ties into the presentation here today. And please just come off mute and jump in with your thoughts. No need to raise hands.
I can provide a little insight maybe for that. When I was going through dental hygiene school 100 years ago, I did have opportunities to see patients with special needs, but the clinical instructors wouldn't allow it because they were higher risk for having some kind of a emergency situation, which probably wasn't the case, but the whole patient management piece. Also, during training, your appointments are, can be 3 hours long too, which isn't always the best situation for certain special needs situations, and the reliability. So like what Dr. Sean was saying too, if it's not a great day, maybe it's not a good day, to be a patient for somebody who's just learning how to be a dental hygienist or a dentist.
I love that. And I think too, Sean, what really resonated about your presentation was talking about the systems level piece as a public health professional. That of course resonates, and at AIDPH we've really kind of shifted. Obviously health equity is at the forefront, but talking about looking at oral health justice and that being a piece at the systems level so that we can achieve that equity piece through the systems change. And I just wonder if anyone has seen or thought of innovative systems level pieces that can address some of those pieces, like the scheduling or more flexibility. That's a pretty big question, but I'm wondering if anyone's seen any innovative programming around that.
I might be able to speak to that a little. I do currently teach dental hygiene. I've been in education for this is my 20th year teaching. So there have been some things that have changed over the years. Our accreditation standards do require that students learn about special needs patients and treat special needs patients. So we do have that in our curriculum. We just adjust those appointment times depending on the patient. And of course, there's that chance that a student may not have a patient in the chair that day, but we know that and compensate for that. So I do feel like there's a little bit more, there's definitely a lot more education about special needs and equity for people with special needs in dentistry, far more than there was taught in the 90s when I went to school. So I do see that we're improving on that, but still room for improvement.
Thank you. I'm glad that that's what you're experiencing and you're seeing those changes. And thank you for sharing that with us. I'm wondering if folks also, part of the point of having a community discussion around this is thinking through how we can go back to our own communities, our own work, and make change on these topics. And kind of thinking through the rurality specificity of this presentation and talking about that systems level. Obviously, Sean covered a fair amount of that in his presentation, but are there other specific challenges related to healthcare infrastructure in rural areas that we haven't covered that we should be thinking about as a group, that we should be thinking about with finding innovative solutions to overcome?
I can speak to that a little bit, maybe. Um, I work primarily, my full-time job is with a school district. So I recently, last year, expanded the program to include what the school, they have a program called Life Skills Program. So I have reached out to those students, those kiddos, to offer preventive services for them. And in the process, I also reached out to a group, it's a small group called Medical Sensory Meds, Sensory Med. And that gentleman of that company was amazing. Like, he provided so much information to me on how I can create an environment that's more sensory friendly, not only for these kiddos, but for all my kiddos, first grade, kindergarten, So through that whole piece, I feel like I've been able to just share, like communicate, like these needs and the importance, not like with the community, the school community, with the teachers, with the social workers, with the parents, with, exposing, talking to students about career options, and like this is an area also that you can, potentially work in. So that's one of the things that I am trying to work on, is just the communication piece, the education piece, not just with the dental community, but the community in general. And to answer a question that you had asked earlier, Liz, I'm just curious whether there is, because there was a group in Connecticut, a task force that was like a remote piece that talked about working with students and providers to help individuals with disabilities. So I'm just wondering if there's potential for some sort of a continuing education piece. I'm thinking it would probably have to be very, very small group of individuals that would offer some mentoring opportunities for providers to help them feel, more comfortable if they haven't had those experiences with working with individuals with disabilities. So just some things that are just kind of been running through my head during this presentation. Thank you.
Well, I love hearing that your wheels are turning, and I really love your experience in that communication out piece. That's really fantastic to hear, and I think that's something that we always hope to replicate, right? And I think when we're talking about a lot of public health programming, programming to increase equity, a lot of the pieces we're coming up against are staffs. We're talking about that school environment, staffs that are maybe under capacity, over capacity, don't quite have the ability in their allotted hours to kind of do that extra set piece. So I'm curious if you're interested in sharing more, if there's something specific about your role or your funding that allows you that time that others could replicate in their programming to get a champion to share out with more people. And Sean, I'm wondering if you have any thoughts on that CEU question and that mentorship piece.
Yes, I'm trying to think about what I can say and not at this point, but we are with AIDPH, so my organization and AIDPH are moving forward probably in Q4 of this year to do something just like that. We're looking at the platforms and the processes that we can set that up. The pilot will be in Tennessee, so we'll do it at a state level to initiate, but obviously the goal would be to replicate and scale. And if Annalise is on here, I'm sorry if I said something I shouldn't have, and nobody tell on me, because I know we were waiting to put that out, but it is a great idea, so much so that we are moving it forward with the state of Tennessee, with their funding, actually. So exactly what was coming up within the analysis and research that we had been doing, this is what we were being asked, especially from dental hygienists, I'll point out, would seem to could have the opportunity to kind of carry the torch forward on this, because we're getting more input there. And then just one more thing to what Donna said, which is the life skills piece. That's a big request coming into my nonprofit, because oral health is, the knowledge of oral health is growing. And so a lot of teachers at either the high school level or working within these independent facilities that help individuals become more independent, they need help with oral health and oral hygiene instruction. And keep in mind, it's a different process, especially for those that happen to have Down syndrome or on the spectrum, because they need a different process. So they have to, everything has to be a step-by-step process. So they're trying to work to introduce those step-by-step processes. And the asks are, do we know a hygienist? Do we know a nurse or somebody that can come in and help us? Because they're educators, they're not clinicians, or they don't have that field. So I would say it's so important to start delving into that, especially because there's a big curriculum change a year ago where they have to now have health, hygiene, dietary counseling. All of that is now part of these life skill curriculum.
Hi, sorry, I was looking for a way to raise my hand. My name is Albert, so I'm calling in from the UK. So the time zone, sorry, I joined in really late. It's almost 8 p.m. here. So just to ask a quick one, would the recording be made available? Because I'll need to do some catch up of, I missed about 40 to 50 minutes of this. But
Oh.
I think, yes.
Yep, recordings will be posted in the next few days and we'll email them out.
Okay, just if I might just add, I think it's almost what we same problem because I had the oral health program in my local authority, Medway Council, and I think and that's why I'm really interested in this topic because, those in rural settings, it's difficult to access dental care, and I think one major problem we found out is logistics, where a lot of people can't go to the point of care, dental practices, and they are far flung. And if they don't have access to vehicles and they have to go by public transport, then who funds that? Because if there's a cost of living crisis, and so when a mom thinks of getting a taxi to take her and the kids and she doesn't have any support system, that usually has a strong impact in accessing dental care. So for some, they would have an appointment with their dentist because here in the UK, we've got like a national health service scheme. So even if they get the dental appointment, which for under 18s is free, the thought of the amount of money to pay to to transport herself from her house to the dental practice and back is usually a challenge. So I think that's one area where, we've started having conversations about in terms of logistics for families who are in far-flung areas. But we just ask, is that a problem maybe you guys in the US are facing in terms of access to dental care? Um, just to trade ideas and to see how I can help improve our program. So I think that's why I like joining this program because I get to find out what you guys are doing in the US that works and to see if it's similar to what challenges we're having here in the UK and how, can address the issue. But that's one problem. So if anyone has any solution to that or how they've worked around logistics in accessing dental care, that would be helpful. Thank you.
Yeah, thank you, Albert. And welcome back, folks who were in the breakout rooms and coming into this conversation. We were having a great discussion about the different systemic barriers that face and potential innovative solutions. And Albert's joining us from the UK, so is sharing out, wondering if maybe some of those same logistic barriers exist. And I think the answer is yes, right? We see that over and over again with many populations, but rurality specifically. And I think the key is that we see anecdotally doing rural programming every other month and hearing from different communities is that those transportation issues exist, and they exist in unique ways based on the geography and type of location. So in one place it might be no access to buses or long transportation. In another place it might be snow and the fact that folks can't afford snow tires to drive in the winter. So there's a whole portion of the year where they can't travel. So I think the key that I hear is really kind of making those community connections and hearing from the community what the pain points are to find the solutions to overcome. We're gonna head into our closeout here, but for folks who are in their breakout room, since we're getting close to time and don't have enough time to do a full check-in, if folks are so inclined and want to share in the chat maybe some broad themes and or resources that were shared during the discussion, I hope everyone was having a good and robust discussion in their breakout rooms. I invite you to share that in the chat. And Sheila, I will ask you if you're able to bring up the slide deck so that we can just touch base on our final closeout steps. The question that came up as well was about our recordings. So our next steps include that CEUs are available for today's session. Sam is going to post that information in the chat. For those of you who have joined us on a seminar before, we have a bit of a new CEU process. So it is now hosted on our Academy. If you have not already registered, you will be asked to register when you follow the link. The great part of this is you're able to very easily access all of the past recordings from this year's session and past year's session. You'll be able to access the competency quizzes to earn the certificate at the completion of this series. Again, this is our last series here today, and you'll be able to house all of your CEUs through our rural oral health seminars and as well as our other AIDPH programming. It is a new process, so if you have any questions, please let us know. Sam, do you actually mind popping your email in the chat as well? Please reach out to Sam. Please let us know if you come up with any issues on that new process. So again, resources and recordings from today's session will be posted in the next few days, and we'll email out a reminder. This is the end of the 2024 session series, but it is not the end of our rural oral health series. We will have a new series, a new theme in 2025. We are about to post our dates for 2025 sessions, so keep an eye out for that. And keep an eye out for the theme at the beginning of 2025. So I think that those are all of our next steps. If anyone has any final questions, you can pop them in the chat. And again, I just want to say thank you to everyone for your dedication to this work, for joining us here today, and for engaging in a wonderful community discussion. And have a wonderful rest of the week, everyone. Take care.
Thank you, Sean. Bye.